enjoying this lovely fall weather. This is the third in line of 4 webinars that we are doing at BC CDC at TB Control in partnership with BC Lung. This is the part of our strategic plan to improve TB literacy in the province. The first webinar was the TB or not TB. The second webinar is TB here and now we are looking at TB treatment to cure and to protect. Our last webinar will be in January 4th, and it will be around contact investigation. So just wanted to welcome everybody and thank people for signing up. Our presenters today will be myself. I'm Nash. I'm one of the nurses at TB Control, and one of our newest staff, Karen Beinhaker, has been a fabulous addition to our TB services for Aboriginal communities. And so if you go through our slide deck now, if I can, sorry, I'm just trying to get into, there it is, slide one. So we're just going to look at the overview, and you can look at, we're going to look at what we've previously talked about. We'll look at medication regimes, commonly used drugs, adverse effects, drug resistance, DOT, and then our lovely Veda Peters from BC Lung will be talking about TB treatment and smoking cessation. And then we'll have some time for question and answer. I'm going to look at our next line, the learning objectives. You can take a look here. How we'll break this down is I will start. Well, obviously you're welcome. Karen will go through the backup of what we've done before and bring everybody onto the same page. You can see the learning objectives here, and then we'll continue on.
Hello. So I'm going to review some of the abbreviations and key terms that you will see in this presentation. TB bacteria. This is the name of the bacteria that causes TB disease. LTBI is an acronym used to describe a latent TB infection. A person with a latent infection has the TB bacteria in their body, but has no evidence of clinically active TB disease. MDR-TB is an acronym used for multi-drug resistant TB. This term is used to describe cases of TB that are caused by a strain of MTB that is resistant to both INH and rifampin. These are the drugs most commonly used to treat TB disease. Cavitation, or a cavity, is a chest X-ray finding in some cases of pulmonary TB disease that provides evidence of lung destruction. Cavities generally harbor a large amount of bacteria, and as a result, patients with cavity disease are likely to be highly infectious. Tuberculosis, etiology. Tuberculosis mycobacteria complex. So mycobacteria are members of bacteria family. These organisms can cause a variety of diseases. Some mycobacterium are called tuberculosis because they cause TB disease or diseases similar to TB. In Canada, the majority of TB cases are caused by an organism called Mycobacteria tuberculosis.
And so what we'll see in our, we'll have MTB, obviously that's Mycobacterium tuberculosis. We'll have MOTS, Mycobacterium, other than tuberculosis, and MAX. So we're obviously very interested when it's TB, because then we're looking at, is it infectious, is it not infectious? So there's a group, there's a family, as Karen has mentioned.
So what is TB? TB is an infectious disease, as we mentioned, caused by the Mycobacteria tuberculosis. While TB can occur anywhere in the body, including the lungs, kidneys, bones, and brain, it primarily attacks the lung.
And when it's in the lungs, it can be aerosolized, and the droplet nuclei will come out, and that's when TB is infectious. You can have active TB disease and not be infectious. We're always uber concerned as public health when it is infectious.
So untreated, with appropriate treatment, TB is usually curable. However, it holds great potential for serious harm and can be fatal in 50% of those infected.
So what we'll be doing today is looking at both globally in terms of what happens with TB, and then locally. We've gone through previous subsets of webinars where we've actually looked at what is the picture of TB. So when we're looking at 50%, that is a global rate.
So there are two main types of TB disease, non-respiratory TB and respiratory TB. Non-respiratory TB is also known as extrapulmonary TB. It refers to TB disease that occurs in other places than the lungs, such as the lymph nodes, the pleura, the brain, the kidneys, or bone. Most types of non-respiratory TB are non-infectious, and the symptoms depend on the part of body affected. So for example, if a client has TB of the kidneys, this may cause blood in their urine. If they have TB of the spine, it can cause back pain. The second type of TB disease is respiratory TB. This is TB disease that occurs in the lungs. Respiratory TB is typically infectious prior to treatment, and the main symptoms include a cough lasting longer than 3 weeks, chest pain, coughing up blood or sputum. The majority of TB cases occur in the lung. In Canada, approximately 75% of TB disease is respiratory TB.
And so what we're looking at as well as within this lovely graph here, the non-respiratory, and sometimes people will actually be identified as empiric treatment, or we're thinking about TB, let's treat them. So it's very important that we look at what we're looking at, and so you can be treated with TB and not have a diagnosis because we've looked at your x-ray, we've looked at the history, and the TB physician goes, look, you know what, this looks like TB, let's treat you empirically or suspect TB, and that's where kind of the unknown and so forth. So it's really important to look at the whole picture when we talk about TB.
How is TB transmitted? As we mentioned earlier, TB is transmitted almost exclusively through the airborne route. The risk of transmission depends on the concentration of airborne particles in the air. Transmission is more likely to occur when there's a higher concentration of MTB in the air. As a result, transmission outdoors is unlikely. The three main things that affect the concentration of bacteria in a room are the size of the room, ventilation, and the air cleaning system.
So really, when we talk about, when we ask the public health nurses or the community health nurses, where has the patient been, what is the environment, we look at all those kinds of issues, and this is why.
So again, TB is spread person to person through the air. Any activity that aerosolizes MTB can increase the likelihood of transmission. So transmission usually occurs when a person with infectious TB coughs, sneezes, laughs, or sings.
Where we look at in terms of transmission, in terms of infection control in hospital, it's in those invasive procedures where people are actually going in and doing face-to-face contact. So that's what we look at in terms of what is the risk of that droplet nuclei.
How common is TB in Canada? The majority of TB cases in Canada occur among foreign-born. They make up approximately 67% of the cases.
And again, in terms of what we see in BC, we average 300 cases. This is our 2011 number. Majority are foreign-born. We have, 15, 17% Aboriginal. Non-Aboriginal is the breakdown here. And last 2011, 269 cases.
TB pathogenesis, initial infection. So not everyone who breathes in the TB bacilli will develop TB disease. In fact, only 5% of people who breathe in the TB bacilli will develop the disease. This is called primary TB. The other 95% will develop something called a latent infection. TB disease develops when the immune system cannot keep the tubercle bacilli under control and the bacilli begin to multiply rapidly. This can happen very soon after infection or years later. Unless treated, approximately 5% of people recently infected will develop TB disease within 18 to 24 months. This is called primary TB disease. Some conditions can increase the risk of developing TB disease. This typically occurs when the immune system is suppressed. So for example, a client has diabetes or HIV. Some common presentations of primary TB disease include pleural TB, TB meningitis, and miliary TB. The greatest risk that this type of TB will occur is in children under 5 and clients with HIV due to their weakened or immature immune system.
So when we're doing contact tracing, we've always say, who's our high risk group? It's those kids under 5 and those immunosuppressed population in our communities. So we're always uber concerned and diligent around that because we want to make sure that they don't break down with TB and severe types of TB.
Latent TB infection. A latent TB and LTBI is an acronym that is used to describe a situation when a person is infected with the TB bacteria but has not developed TB disease. This means that the tubercle bacilli are in the body, but the immune system is keeping the bacilli under control and inactive. The immune system does this by producing special cells that surround the bacilli. The cells form a shell that act as a fence that keeps the bacilli contained and inactive. People with latent TBI are not infectious and they do not have any signs or symptoms. Some people with latent TBI can develop active disease. This can happen very soon after infection or years later. The risk of developing TB disease is highest within the first 2 years. Reactivation typically occurs when the immune system becomes weak and cannot keep the bacilli contained. The TB bacilli begin to multiply rapidly and break down the wall surrounding it. This client now has TB disease.
And so just to go through latent TB infection disease, latent TB infection, you don't have the TB, you're not contagious, it's preventable. Disease is when we worry about you could spread it if you're infectious. We're just going to flip through the slides. These are the high risk patients in terms of HIV. Obviously, we've talked about people who have children under 5. And then we'll continue to look at who's in increased risk of TB in terms of underweight, if you have an abnormal x-ray, diabetes, as Karen has mentioned, and then smoking is a small risk. TB is preventable, totally curable. We want to really look at treatment rates and getting people treated for latent TB infection. The current standard?
The current standard treatment for latent TB infection is INH and vitamin B6 for 9 months. INH is very good at killing latent organisms. It's both effective and inexpensive. There's extensive research to support its use. A 9-month treatment typically provides 90% effectiveness. Therapy can be both daily or intermittent at 2 times a week. If a client is on intermittent therapy, they must be on DOT. DOT means a trained healthcare provider watches clients swallow each dose of medication. In some situations, drugs other than INH may be used. For example, 4-month rifampin treatment may be recommended if a client can't tolerate INH or has been exposed to INH-resistant TB organism.
We're certainly going to be talking about specifically around INH and rifampin in the next few slides.
So the window period is a time between a contact's date of last exposure to an active case and when a TST or AGRA can reliably detect MTB. As you mentioned before, children under 5 have an increased risk of developing active TB once infected. They also tend to develop the more serious or life-threatening forms of TB like TB meningitis or miliary TB. In order to protect this population, all children under 5 who are contacts to an active case should be medically assessed for TB disease, including a TST and a chest x-ray. Once disease has been ruled out, they should receive latent TBI treatment, even if the first TST was negative. This is called window prophylaxis. If at 8 to 10 weeks from the date of last contact their TST is negative, window prophylaxis can be discontinued.
So, I'm sorry.
Presumptive latent TBI treatment. Because of their weakened immune system, patients with advanced immunosuppression are at high risk of developing TB disease. Because these clients may not be able to mount an immune response, they are more likely to have false negative results.
Very much like an HIV positive person who has a CD4 of less than 100, your skin test, and they're not going to build an immune response. They've been in contact with cases. There's a high risk that they're going to break down. We're going to be treating them for latent TBI. There's always now the T-spot, an interferon gamma release assays that may help with diagnosis. So it's really important that we talk about that. I know that there's some questions around why we're latent TB infection. Should we treat all of them? We always look at risk factors. We'll talk about B6. The next few slides we're going to kind of look at in terms of some of the questions that have come up. In terms of the latent TB, the biggest adverse effects are around hepatotoxic in terms of liver enzymes, and the older you are, looking at alcohol consumption. Obviously, if you have hepatitis C or cirrhosis, that's going to include. Around with the B6, we always look at INH with B6 because there's piriform neuropathy, and if you can stop those kinds of side effects from happening, people are more likely going to continue on therapy. We're certainly going to go through the profile of each medication as this lovely webinar continues. One of the, again, side effects and adverse effects of INH, nausea, vomiting, and if you have signs and symptoms of liver toxicity, we'll always recommend that you stop medications. Right, and so I know this is very exciting for you guys. We're now looking at treatment and cure of TB disease, and so this particular slide is of a sanatorium in 1926. This was the age where we didn't actually have medications, and the best what they thought helped kill TB and the TB bacteria was sunlight. So you could bed rest, fresh air, and sunshine. And we call this now a holiday. But so keep in mind, it's really important to know that these TB medications, the red capsules are rifampin, the blue ones are ethambutol, the bigger non-scored medication is PZA, pyrazinamide, and the other one is INH. The small white tablet is B6, and we'll continue to talk about these. These medications were introduced in the 50s with an injectable streptomycin and then PSA, but we're using the same first-line medications that we have for a very long time. So it's really important to know these drugs, love these drugs, and get to know the side effects. We're kind of going to look at why we do what we do. You know, we want to make sure that we prevent people from breaking down with TB, latent TB infection. What are your risk factors? And we've talked about that in previous webinars. And then we want to make sure we cure TB, obviously, and then we make sure that there is no drug resistance. So it's really important to know why we're doing what we're doing, and then obviously to prevent relapse for a cure. Again, just to reiterate that the length of treatment is not specifically the time of the prescription that you're offered. So it's a 6-month therapy. We'll review that. We'll certainly talk about this throughout the next 20 minutes of this webinar in terms of all those indicators. And so principles of treatment. It's really important with tuberculosis that we hit them with everything. So we always say throw the kitchen sink at it. We have these great first-line medications like the isoniazid, rifampin, pyrazinamide, and ethambutol. We don't ever want to start somebody on latent therapy without excluding active TB disease, because then you put them on monotherapy. If we learn from what has happened with the HIV movement, so early on in the late 80s, early 90s, everybody was put on AZT, which is an antiretroviral, and they've learned from TB, and they actually use NNRTs. They use a number of medications. So when you're on antiretrovirals. And so they've learned from TB and TB management and thrown a lot more meds at it because it actually helps curative rates, it helps break down resistance, and we'll go from there. So again, on the point 3, I'd like to really, the duration of therapy is based on which drugs if we use. If we're using a first-line drug, if everything's going well, there's no adverse response, if your smears and cultures are converting, we'll certainly talk about that. And then we consider directly observed therapy. As Karen has so eloquently mentioned, DOT is actually when a trained healthcare professional goes in and monitors taking the drugs in and around side effects. We do have our partners in health authorities that use modified DOT, and we just want to make sure that we support that as well. So that we always look at gold standards when we talk about TB and these particular webinars, but there's adaptations locally. Again, treatment. This is just a little bit of an overview. Really important to look at the intensive or initial phase of medications. It's generally the first 2 months, and we really look at which medications you're on, INH, rifampin, PZA, ethambutol, very much our combination. We really want to make sure that you're on a daily regime, and so we want to make sure that we're hitting the replication of the TB germ where it lives. So each mechanism of the drug will hit it at a certain phase, and we'll talk about that. The continuation of phase is generally minimum 4 months. Again, treatment is based on what medications are on, how much disease they have, and then how they're actually responding to medications. Have they converted their smears to smear negative? Have their cultures converted? What does their x-ray look like? So it's all a combination of these things, and it's really important. If the initial phase, the first 2 months, had a suboptimal, let's say we had to stop PZA because of liver toxicity, that increases the therapy. What happened in the continuation phase was their adherence issues. So it's always that multiple layering effect on why we do what we do in terms of the regimes, the length of treatment, and are we treating to cure? All right. Drug used in treatment of TB disease. These are our first-line drugs. You've seen a picture of them. We all love INH, ethambutol, PZA, and rifampin. Our second-line drugs, the fluoroquinolones. I practiced that and I said it wrong again. If you're on those medications, it certainly increases therapy. There are injectables, and then the side effects in terms of the toleration of medications. In sub-Saharan Africa, where there's a lot of drug resistance, you're seeing a lot of use of second-line drugs, therapy that lasts a really long time, and then adverse effects like losing your hearing and so forth because you're using medications that are not as well tolerated. So again, the first-line drugs in Canada, INH, it's a great drug. It obviously prevents the development of drug resistance, and it also is really great at when the TB germ is actively replicating, it'll kill that germ. So it's really in our arsenal of TB weapons, INH is our best weapon. It's a great drug for preventative therapy, and it's really our backbone for active TB disease. And so we look at rifampin. Rifampin is a really great sterilizer. It greatly reduces, obviously, the capacity of that TB germ to replicate because it sterilizes it. And it actually is another, with INH, a backbone. If you have rifampin on board, your duration will be shortened. And it'll certainly be shorter than 12 months.
Mm-hmm. Rifampin is also excellent at killing latent organisms.
And again, we talked about that 4 months of preventative therapy earlier on. We're doing clinical trials at our clinic in Vancouver to look at the efficacies of that. Our gold standard is INH. INH is 9 months for preventative therapy. And so we're looking at, in Kelowna, where there's a drug-resistant profile, we always look at rifampin because there is some low-level resistance. So we look at that drug profile as well. Again, PZA or pyrazinamide. It's really important to have this drug on board in the first 2 months. It's really, it's actually a very misunderstood drug. It's again a very good sterilizer. It's the super duper sterilizer, and it's really effective in the first 2 medications. It does exacerbate gout, and if somebody has gout, it does exacerbate it. If we take it off, and it is a culprit of liver toxicity as well. So if we take that off for the first 2 months of treatment, their duration increases. So it's really important to have that education and that fundamental piece for patients to know, yes, this is a common side effect, but if you can ride it out, your duration will be a reasonable duration in terms of the length. If you have pulmonary TB, we're looking at 9 months. And so if you can tolerate that PZA for the first 2 months, you'll have a good trajectory. Otherwise, your treatment has increased. If we look at ethambutol is a great drug in terms of it's an extra role, and it's an extra agent to make sure we there's no resistance.
Mm-hmm.
Vaccine. Okay, so really great that it actually is a bacterial static drug, and so once we hit sensitivities, once it's fully sensitive, we actually take off ethambutol. And then we're actually going to go through each drug and talk about side effects as well. And then again, second-line drugs in Canada, there's injectables, and I've talked about that there certainly would increase the duration of treatment. The second-line drugs are less hepatotoxic. So there's actually a really good thing is if they can't tolerate PZA, INH, or rifampin because of liver enzymes, we can put on some other agents. INH, what we see in clinical care is people really complain about fatigue. That dissipates. INH, you get lots of neuropathy. You put them on B6, you resolve that issue. The big thing around hepatotoxicity, you're going to do your baseline liver enzymes. You're going to make sure they're okay even before you start them. With preventative therapy, make sure you get that all on board. For active TB disease, there's rifampin, there's PZA, and there's INH that will cause that hepatotoxicness, and we'll take a look at that. And sometimes what we do is we stop medications and we introduce one med at a time. Again, if a patient has nausea, vomiting, as you look at here, we would stop the medications and then we'd reintroduce. But INH, those are the big ones. People really complain about fatigue, numbness, and we make sure that there's no liver toxicity because we're doing blood work. Rifampin, very similar profile to INH in terms of liver toxicity. One of the important things to do the patient education in terms of rifampin, it changes your, if you're wearing contact, it has a red tinge to it. And when I was an outreach worker, I had a person on rifampin. I forgot to do the education piece in terms of it makes their urine turn red. It was very uncomfortable for the patient as they thought they were bleeding out. So good education piece. With both INH and rifampin, there is that need for using additional birth control. Rifampin more so than the INH. So we want to make sure that they have barrier methods. Rifampin has definitely much more contraindications with other medications, coumadin. You want to make sure that if they're on antiretrovirals, that you maybe switch it to rifampin because it does affect methadone intake and it affects NNRTs. So to know that drug profile, although it's really great in killing the TB germs, and for preventative therapy, it does have a lot of other contraindications. PZA, again, a very similar profile with both rifampin and INH in terms of hepatotoxicity. It's really important in terms of it exacerbates the gout, and the big thing is GI upset. For any medication, we recommend that medications be taken on an empty stomach. People do talk about, oh, I've got a tummy upset, or we say, eat something light. It's really kind of in and around your nursing care and looking at how we can make these medications tolerable. They're very toxic and they can cause damage. So we're going to monitor their liver enzymes, we're going to monitor their side effects, we're going to deal with their side effects, so then you can have a great treatment outcome. So in terms of tiredness, you can possibly take them at night. In terms of obviously your liver enzymes, your jaundice, you're going to stop the medications. In terms of slight stomach upset, have something light to eat. Just to make a note that medications in terms of, sorry, I'm missing my train of thought. I'll continue going around the GI upset and we'll go from there. Ethambutol. Ethambutol is, again, a drug that we take off when we get the sensitivities. Really important to monitor visual acuity and color acuity. And people can have adverse effects and lose their vision sight. So that's something that in terms of your circle of care, whether it's the physician or the nurse that does it, we want to make sure that that's monthly. And it's really an important piece in terms of ethambutol. So summary, rash, any drugs, GI intolerance, any drug, hepatotoxicity, PSA, INH, and rifampin, and that's in order. And then the peripheral neuropathy is INH, optic neuritis, ethambutol, PSA, gout. So knowing what your medication does and knowing the side effects and addressing that in terms of your good patient outcomes. Monitoring drug treatment adverses, we're going to just continue that. Really important in terms of latent TB that we do baseline liver enzymes because we know that that's the biggest culprit in terms of side effects. Again, with active TB disease, you want to make sure that you do CBC, you do platelets, you do alkaline phosph, and you do baseline hepatitis serology. You'll do, they have active TB disease, you look at HIV. We can provide that information. All this is really great information, and it's you're not doing this alone. We're working in partnership with you, and there's always going to be a warm line, a warm person to call. You can phone Michelle, you can phone Lynn, you can phone Mary Jean, heck, you can even phone Karen and I. So we'll help you through this to manage the side effects, and it's really important in terms of patient education because they're a part of this. If they know the adverse effects, they can identify it. In terms of drug rashes, we want to make sure the mild stuff we can treat. The generalized we require intervention. So we may change medications, but we want to make sure that if that happens, that they know what's going on and they seek medical assistance, and also you're assessing those as well. Again, intolerance. Again, in terms of liver enzymes, we take a look at that, and if you look at the last point, if no hepatitis, we consider changing dosing times and taking dosing with food because of the GI and the stomach upset. And this is a note that I actually wanted to, and acids can interfere with TB drug absorption. So just keep that in mind. So in terms of rifampin and INH, you want to look at barrier methods. In terms of all of the medications, you want to look at baseline liver enzymes, and then you want to make sure that any of the side effects you address with patients. Hepatotoxicity we've kind of talked about, and we'll kind of continue. And the managing potential side effects, really important to confirm, manage, and assess that patient, and really look at their circles of care. Who is their primary healthcare provider, along with the community nurse or the public health nurse? It's that physician or that physician at TB control. And if we can manage people's side effects, treatment outcomes are better. Again, we want to reduce the signs and symptoms. Responding to treatment, this is actually quite important. We actually do look at what's happening with the responses to, if they've had a positive smear, we need 3 negative smears to say that they're not infectious, and sputum should be submitted regularly to get those conversions. The next few slides we're going to actually talk about response to treatments. The sputums are cultured at the second end of the month, and then we look at when did those smears and cultures convert to smear negative, culture negative. again with the chest x-ray, should be done at 2 months and at 6 months of treatment. Sometimes what you will see in the field is prescriptions for 6 months. That is not the end of treatment. That is when we assess. We look at all those factors and then we determine whether that patient needs another 3 months. That's a great potential for misunderstanding and miscommunications, and then the patient is assumed it's a 6-month treatment, but in fact this is when we reassess and we look at it. So it's very important to get those communication piece and know why we're doing what we're doing. And drug resistance is caused by organisms that are resistant to one or more. We actually do drug resistance profiles and you get sensitivities right away. We also look at if they're not converting their cultures, are they absorbing the medication? So we can do absorption as well. And the impact of drug resistance, as we know, longer treatments, public health issues, and it's complex, it's lengthy, poorly tolerated, and very expensive. And it's really horrible for patients. And we can prevent that. Just my little chat about directly observed therapy, that is the gold standard. It is the World Health Organization's gold standard, and if we can do that and work with patients to do that, I think that is kind of what we're going to do. And simply, as Karen said, it's monitoring each dose. And it is an allied health care professional that does that, a trained person. Again, we're just going to continue because I'm kind of aware of the time. Medications are fairly well tolerated if we're monitoring them. Kids tolerate it really well, and making sure that the patient is part of the treatment and they know what's going on. So educating clients about TB and their treatment. And just in terms of this last slide, ordering medications. Once we get the prescription to you, you get 2 months of medications. You dispense 1 month. If they're self-administered, they come back for that 2nd month. You put in the reorder medication, send it out to us, to fax it or mail it. You get another 2 months. And so we'll actually look at that, and that is a little helpful hint because we've heard from you guys that it would be nice to do that. Now our lovely partner at BC Lung is going to be talking about TB treatment and smoking cessation. Hold your excitement.
Yeah, please do. So you're going to probably be wondering why it is I'm harping on TB and smoking cessation when it's really considered to be a minor risk factor. Unfortunately, tobacco use is a factor in any chronic disease. It just makes it worse than it needs to be. So there is a place for tobacco cessation in TB management. And we're going to talk about the 3 A's, the rationale. Quitting smoking is the #1 thing that anybody can do to improve their health. So it only makes sense that you have that opportunity and you are in a unique position to take advantage of that opportunity to advise people. Nicotine metabolism, mostly in the liver. You're dealing with drugs that are already hepatotoxic. Nicotine increases the metabolic rate generally, so that some of those drugs will be excreted and metabolized much quicker, therefore reducing their efficacy, and nobody who's taking TB drugs really wants to extend the length of time that they have to take those drugs beyond what would be most beneficial and curative. So what you need to do every time you see that patient, ask about tobacco use. Does anybody in your family use tobacco? Or do you use tobacco? If the answer is no, congratulations. You've chosen a really good, healthy lifestyle. If it's yes, then you go to the 2nd A, which is advise. Your role as a health provider, a lot of smokers believe that if nobody asks about their tobacco use, that it's not an issue. But it always is an issue, and you should never be unwilling or slow to ask about tobacco use because it is so important to their health. So in this unique position, you get to advise them to quit. It's always a good thing to do. You know the benefits of quitting as well as I do, so I'm not going to go through those. But it's healthy for the patient. It's healthy for the family. Again, you assess their readiness to quit. Simple question. Have you thought about quitting? If the answer is no, well, okay, shelf it for this time, table it, we'll ask at the next visit. If it's yes, your opportunity to say there's help available. I'll be here if you want to talk about it, or you can do a fax referral to Quit Now, advise them to call 811, get their 12 weeks of NRT free from the government once a year. That's all you have to do to qualify. And it's really that simple. It doesn't have to be a big deal.
That was exciting. Well, I learned a lot. So we're going to go back into our last slide. There's a couple of questions. I didn't realize we had so much time. I think they just wanted me to clarify that last lovely slide. When ordering anti-TB medications for latent TBI, this is the example, we do the prescription, all prescriptions for both latent TB infection and active TB disease are generated by the physician at TB Control. That then gets sent to our centralized pharmacy who will dispense all medications, and that will go to your lovely health unit, your physician's office, or our lovely partners in First Nations communities, for example. So you'll get 2 months of medications. So let's say this person, Karen is my lovely client. I've done my baseline liver enzymes because I've listened to my webinar, and I know that the side effects of the INH are peripheral neuropathy and hepatotoxicity, and so we've reviewed all that. My medications have come in. She's self-administered. I'm going to dispense 1 month's medication, talk to her about the signs and symptoms, if there's anything, and in terms of so I'm going to give her a month of INH and a month of B6. So she's going to have 300 milligrams of INH, 25 milligrams of B6. She comes back the next month. She brings her empty blister pack, and then you have that other month. You dispense it. She says, oh, how, you go, how's it going, Karen? And she goes, a little bit more neuropathy. You phone us up. We say increase to B6. You may have some in your stockpile. If not, we'll order you some. You give it to her. You give it to her, and then you put in your reorder. So that 85, whatever the reorder medication number is, 850, I think. And then if you're doing DOT, you're doing your DOT form, and that is your medication reorder. And you either fax it to us or you mail it to us. So then you get another 2 months of medication. So on those reorder forms, you can certainly do a cover sheet. You can say, hey, she's doing well. And then we'll also look at the adherence piece. So we'll look at how much medication she's taking. So we'll look at that in terms of adherence and look at that in terms of drug resistance, if it's whether it's absorption, whether we need to look at what else is going on for the patient. So it's that collaborative piece, and in terms of reordering that medication, we want to make sure you're always having that extra month. So you dispense that second month of medication. They've got a month on with them. You'll get another 2 months. So you always have medication on hand. I'm just looking at the questions. And they've actually talked about people like, why on the 939 do you have question around Hep A, Hep B, Hep C? And again, because our frontline, our first line medications, our INH, our rifampin, our PZA, their drug profile is that they're hepatotoxic. And we want to make sure that if they have underlying hepatitis or cirrhosis, that we actually may look at a higher AST or an ALT in terms of monitoring. So for example, not that everybody in the downtown has a higher AST, or they tend to have, the population that we work with have hepatitis C. Again, in the downtown east side, they're on preventative therapy. We may accept a higher than normal AST. So that's why we want to monitor that, so we know what the patient is and we know the patient profile, so we can adequately treat. Because yes, the medications are hepatotoxic and you will see an increase in liver enzymes. But if they have underlying liver enzyme issues in terms of cirrhosis or hepatitis C, they're already elevated. So their baseline might be higher. I'm just going to look at the other questions and see if there is. The question is BC CDC looking at charting a charting system that would help improve communications between TB control and health units? So an example is our lovely partners in Vancouver Coastal are on Paris. We are on IFIS, and then there is this amazing system called Panorama. And so none of the other ones kind of talk to each other, so there is going to be an interface between Paris and Panorama. And so how can we communicate better? How can we do that? Some of the forms that we've created in terms of the communication piece, great. If we're case managing together and there's questions, pick up the phone and talk to some of our lovely nurses. They're very skilled and they know what they're doing. And we currently at BC CDC and TB services use the IFIS system for our clinical management of patients. We are looking at Panorama, and there'll be a much more interface because then we'll be looking at the same system, and Paris will be interfaced with Panorama. And so the other question is, what if you don't have access to IFIS? Some public health organizations across the province have read-only access, so that's another thing. And again, Karen, my lovely coworker, is like, pick up the phone, talk to us. We're actually here to work in partnership with you to manage cases of TB in the province. That is our mandate. That is your mandate. We want to look at curative regimes, and we want to meet where people are. We want to make sure it's patient-centered, so we will work with you to make sure you get your medications on time. We'll work with you to look at adverse effects and dealing with patient issues. And if there's tools, pamphlets, educational materials that we need, it's certainly within the strategic plan that we are the identified body to actually give you that information. So just let us know. Yes, you can pick up the phone and call us. You can email us. We are available. There is another question, is what is the criteria in deciding to recommend or not recommend treatment for latent TB? That's a great question, because again, in our strategic plan, it is we want to increase the rates of people getting on preventative therapy. And what we look at is really high, are you a high-risk person? What does that mean? The TB or not TB, we've looked at who are those people who are going to break down with TB. So those people who are immunosuppressed, those people who have diabetes. So if you breathe it in the TB germ and your child under 5 and you're a contact, we want to make sure we get you on primary prophylaxis or preventative therapy. The nice thing is right now, we do have a new diagnostic test for latent TB infection, which is the interferon gamma release assay. It is a blood test that can look at if you've had a BCG and your positive skin test. Is that positive skin test due to you breathing in the TB germ? Is it because of what Karen talked about, all these other mycobacterium other than tuberculosis? Is it because of the BCG? So when we've identified, yes, you have a reactive AGRA and you have latent TB infection, what are your risk factors of breaking down with TB? We generally will offer people latent TB if they've had contact, if they're high risk, and if they want to take it. So the criteria is fairly large. We want to make sure we prevent people from breaking down with TB, because if you want to get on latent TB and you have no other issues, you're not going to have any other comorbidities, you're not going to have any liver issues, so most people tolerate it really well. So it's having those discussions because it's voluntary. If you have active TB disease, you have to get treated, and if you are a risk to the public, there's measures that we can do to assist you in taking those medications. Preventative therapy is voluntary, and so we really want to provide you with that education and that information so you can have that patient have that informed decision about being on toxic medications for 9 or 4 months. I'm going to just take a look here and see if there's any lovely questions. It doesn't look like it. We are, I don't know how we're doing at time. We've got lots of time, so I'm just going to review in terms of medications. Our frontline medications, INH. We want to make sure that if we're looking at preventative therapy, you're doing baseline liver enzymes. The other side effect in terms of liver toxicity, we've talked about that, and the neuropathy. And so in adults, INH and D6 go hand in hand. In children, kids 16 years old and younger, we do not do blood tests. and we do not give them B6. They tolerate it really well. If you look at our next lovely medication, rifampin, which is the red capsule, the big thing is around that is they've got, you want to make sure that you use barrier methods in terms of birth control. It has hepatotoxicity, so you're going to continue to do the liver enzymes, and then the changing in contacts and color in your urine, so that's also a big one. In terms of the INH, if I can go back, people do get fatigued, but that dissipates. If you look at PZA, you want to make sure that it exacerbates your gout, and you want to make sure you monitor that, and you want to make sure that people can tolerate it for the first 2 months, because it's a great medication to get on board because it's a great sterilizer. And then ethambutol, you want to do visual acuity, and you want to do your red-green. And then once we get sensitivities, we stop it. We've got another question here, and it's, what's the percentage of meds are required to be taken for therapy to consider completed in preventative therapy? So what we always look at, the gold standard, again, we're looking at gold standard, 100%. So if you have 9 months of therapy and you're taking it daily, 270 doses. What we look at is greater than 80%. We say that it is a satisfactory drug regime and you have killed the TB germ. Anything less than that, we don't consider it as satisfactory. And so in preventative therapy, in active TB disease, we actually look at full treatment and the number of doses. So if it's a 9-month therapy and it's 270 doses, it's 270 doses. Really important to look at in terms of both preventative therapy and active TB disease is you want to get all the medication in. In preventative therapy, if it's a 9-month treatment, you have 12 months to take 9 months. So 270 doses over 12 months is 100% adherent. So we can certainly talk about that, and it does create confusion, but we look at number of doses, and 80%, to answer the question, it's 80% and greater. And so do we treat all cases of latent TB in BC? So again, do we treat all cases of latent TB? No, because it's voluntary. It's up to that patient to make that decision. So if somebody decides not to get on preventative therapy, we'll let them know the risk factors. If they've been in contact, we may suggest that they get x-rays every 6 months for 2 years, because as Karen has said, the greatest risk is in that 2 to 3 years after breathing in the TB germ. Lovely question. Based on AGA results, how is the decision made to recommend or not recommend treatment? So obviously if they are non-reactive, we would not offer preventative therapy. If the person is a high-risk person, they have HIV, they've been in contact with several cases of active TB, infectious active TB, we're going to treat. So it's always looking at those kinds of pieces of the puzzle. So what are we looking at it in terms of the epidemic, the source case? What are we looking at it? How long they've been in contact? Because you're going to treat if you know that there has been an exposure. And then another question, treatment for latent TB is a negative AGRA a guarantee that the client will not need preventative therapy? So it's a great question. Is it a guarantee? In life, there's no guarantee, and in TB, it's not black and white. It's a variance of gray, because my lovely friend Karen here can have just taken 9 months of therapy. Now we're really good buddies, and I have active TB disease, and I'm very infectious. I'm +4. She can breathe in another TB bug. So it's always looking at what's going on for that particular patient. And in terms of if it's DOT, you've watched them take the medication, you've looked at the adherence, we can certainly look at that. There is no current diagnostic tool to say, hey, I've taken 9 months of medication, I've taken 100% of it, can I see if that TB germ is gone? No. But we do have evidence in terms of INH, because it's our gold standard, and we know that if you take greater than 80%, we do kill the TB germ. We're actually doing clinical trials for 4 months of rifampin, and it does look like it's clinically correlated with successive outcomes in preventing that TB germ from breaking down and killing it. And so, again, we know that INH does that. We're looking at rifampin in terms of our clinical study because 4 months is better than 9 months. But because of, again, the hepatotoxicity and then the counterindications of other, if you're on other medications, we always look at all those kinds of issues. I hope you've enjoyed this series of conversations. The next webinar is January 4th, and we will certainly be available for, we will notify you when the next webinar is. So do we, I don't know what the question is, sorry. The next webinar will be on contact investigation. We'll certainly let you guys know. We will send out, the people at BC Longman will send out the emails. If there are things that we can do better, please let us know. And if there's questions that we have not answered, call us, email us, and we'll connect with you. I hope you have a great weekend. And and the evaluation is very important that you send us the evaluations, because we would love to monitor that and make sure that we address your feedback. Again, have a great weekend, and thank you very much.